I've been seeing a lot of revision rhinoplasties over the last several years, and there are many different potential reasons for that. But there are a few common things that we really see with, these fake noses or noses where patients are looking for a revision. Usually it's maybe a dorsal hump that's not reduced enough, or a dorsal hump that was reduced but is uneven between the bone and the cartilage part, or uneven transitions. Sometimes a tip that was refined, but even though it's thinner, it looks still more bulbous, and many times that's because it's just over pinched and there's no support over here. Noses that are over rotated, or one of the things that really kind of gets me personally are nostrils that are just really flared upward, because many of those things are due to kind of faster techniques. I call it a generic rhinoplasty, meaning you're going in and you're doing every nose the same way. You're going to get a few of them right, you're going to get a few of them okay, and then unfortunately the majority are going to end up inadequate in one way or another. So those are the main things we really see, but every patient has their own things that they're looking for in a revision. In the end, it's to get the nose that they initially set out for. And we start with the basics, really. When we talk about revision rhinoplasty goals, we go back to what is your ideal nose. I always sit down with them and I first try to understand what their initial goal was. Then, as with a primary rhinoplasty, we have to understand what anatomy is contributing to the way that their nose looks right now. What changes with revision rhinoplasty is now we're not looking at natural anatomy, we're looking at anatomy that was created by surgery. So there's way more variability. You don't always know exactly what the last surgeon did. We can sometimes guess, but in either case, the normal anatomy has been disrupted. Most of the time, cartilage has been taken out or injured unnecessarily. So we have to understand what we're going for, but now the new surgical anatomy. And then we have to have our techniques. Again, this is really kind of parallels primary rhinoplasty, where we have to pick the right techniques to change the anatomy. But now we have to pick the right techniques to change the surgical anatomy. And sometimes they're similar techniques, but many times they include things like grafting. Grafting meaning taking cartilage from other places if there's any left in the septum or the ears, or taking some rib or cadaveric rib. Because in revisions, most of the time, we're resupporting things that were just very quickly collapsed. Again, going back to the common things that we see with revision rhinoplasty, say collapsed mid-vault over here, we have to put in spreader grafts. Something that's overly narrowed, we also have to resupport that. A tip that looks bulbous but is smaller, well, or nostrils that are retracted. Usually we need to get cartilage grafts and resupport these areas in order to create that final outcome that we want. So revisions are definitely a lot more difficult, but the concepts are very similar to primary. We're trying to figure out what our end goal is. We're figuring out the anatomy. We have to understand which techniques we're going to use to change it. And we have to be willing to also use all those sometimes very difficult techniques. And on top of that, we're also dealing with scar tissue. That's probably one of the most difficult things in the initial part of the rhinoplasty. We're no longer just dissecting, meaning going through soft tissue that elevates relatively easy, but now we have scar tissue, and that can be very dense and difficult, especially when we don't know what the new anatomy is. We have to go really slow, very, very meticulous. I mean, we're meticulous with primary surgery. Here, we're even more meticulous. In some cases, going fiber by fiber to make sure that whatever cartilage was left, we're not injuring that. So really, revision rhinoplasty, it's, primary rhinoplasty, just a lot more difficult. And with patients now, they've gone through the process already and they've been disappointed. So I find that a lot of times, they're at a point where they're just trying to improve their results. And I really feel for patients who set out for an initial result that they had in mind and unfortunately fell way short of that. So that's really revisions in a nutshell. There are many topics that we go to in depth and more specific about revisions, but that's pretty much it.